Rheumatic fever is an inflammatory disease that can involve the heart, joints, skin, and brain. The disease typically develops 2 to 4 weeks after a streptococcal throat infection. Signs and symptoms include fever, multiple painful joints, involuntary muscle movements, and occasionally a characteristic non-itchy rash known as erythema marginatum. The heart is involved in about half of cases. Damage to the heart valves, known as rheumatic heart disease, usually occurs after repeated attacks but can sometimes occur after one. The damaged valves may result in heart failure, atrial fibrillation, and infection of the valves. Rheumatic fever may occur following an infection of the throat by the bacterium Streptococcus pyogenes. If the infection is untreated, rheumatic fever can occur in up to 3% of people. The underlying mechanism is believed to involve the production of antibodies against a person's own tissues. Due to their genetics, some people are more likely to get the disease when exposed to the bacteria than others. Other risk factors include malnutrition and poverty. Diagnosis of RF is often based on the presence of signs and symptoms in combination with evidence of a recent streptococcal infection. Treating people who have strep throat with antibiotics, such as penicillin, decreases the risk of developing Rheumatic fever. In order to avoid antibiotic misuse, this often involves testing people with sore throats for the infection, which may not be available in the developing world. Other preventive measures include improved sanitation. In those with rheumatic fever and rheumatic heart disease, prolonged periods of antibiotics are sometimes recommended. Gradual return to normal activities may occur following an attack. Once RHD develops, treatment is more difficult. Occasionally, valve replacement surgery or valve repair is required. Otherwise, complications are treated as per normal. Rheumatic fever occurs in about 325,000 children each year, and about 33.4 million people currently have rheumatic heart disease. Those who develop RF are most often between the ages of 5 and 14, with 20% of first-time attacks occurring in adults. The disease is most common in the developing world and among indigenous peoples in the developed world. In 2015, it resulted in 319,400 deaths, down from 374,000 deaths in 1990. Most deaths occur in the developing world, where as many as 12.5% of people affected may die each year. Descriptions of the condition are believed to date back to at least the 5th century BCE in the writings of Hippocrates. The disease is so named because its symptoms are similar to those of some rheumatic disorders. Sign and symptoms. The disease typically develops 2 to 4 weeks after a throat infection. Symptoms include fever, painful joints with those joints affected changing with time, involuntary muscle movement, NTS, and occasionally a characteristic non-itchy rash known as erythema marginatum. The heart is involved in about half of cases. Damage to the heart valves usually occurs only after multiple attacks but may occasionally occur after a single case of RF. The damaged valves may result in heart failure and also increase the risk of atrial fibrillation and infection of the valves. Modified Jones criteria were first published in 1944 by T. Duckett Jones, M.D. They have been periodically revised by the American Heart Association in collaboration with other groups. According to revised Jones criteria, the diagnosis of rheumatic fever can be made when 2 of the major criteria, or 1 major criterion plus 2 minor criteria, are present along with evidence of streptococcal infection, elevated or rising anti-streptolysin O titer or DNAASE. Exceptions are chorea and indolent carditis, each of which by itself can indicate rheumatic fever. An April 2013 review article in the Indian Journal of Medical Research stated that echocardiographic and Doppler (END) studies, despite some reservations about their utility, have identified a massive burden of rheumatic heart disease, which suggests the inadequacy of the 1992 Jones criteria. END studies have identified subclinical carditis in patients with rheumatic fever, as well as in follow-ups of rheumatic heart disease patients who initially presented as having isolated cases of Sydenham's chorea. Signs of a preceding streptococcal infection include recent scarlet fever, raised anti-streptolysin O or other streptococcal antibody titer, or positive throat culture. Major criteria edit. Polyarthritis, a temporary migrating inflammation of the large joints, usually starting in the legs and migrating upwards. Carditis, inflammation of the heart muscle, myocarditis, which can manifest as congestive heart failure with shortness of breath, pericarditis with a rub, or a new heart murmur. Subcutaneous nodules, painless, firm collections of collagen fibers over bones or tendons. They commonly appear on the back of the wrist, the outside elbow, and the front of the knees. Erythema marginatum, a long-lasting reddish rash that begins on the trunk or arms as macules, which spread outward and clear in the middle to form rings, which continue to spread and coalesce with other rings, ultimately taking on a snake-like appearance. This rash typically spares the face and is made worse with heat. Synonyms: chorea, St. Vitus dance, a characteristic series of involuntary rapid movements of the face and arms. This can occur very late in the disease for at least 3 months from onset of infection. Minor criteria: fever of 38.2–38.9 degrees Celsius, 100.8–102.0 degrees Fahrenheit. Arthralgia, joint pain without swelling, cannot be included if polyarthritis is present as a major symptom. Raised erythrocyte sedimentation rate or C-reactive protein. Leukocytosis. ECG showing features of heart block, such as a prolonged PR interval, cannot be included if carditis is present as a major symptom. Previous episode of rheumatic fever or inactive heart disease. Rheumatic fever can be prevented by effectively treating strep throat with antibiotics. In those who have previously had rheumatic fever, antibiotics in a preventative manner are occasionally recommended. As of 2017, the evidence to support long-term antibiotics in those with underlying disease, however, is poor. Prevention. The American Heart Association suggests that dental health be maintained, and that people with a history of bacterial endocarditis, a heart transplant, artificial heart valves, or some types of congenital heart defects, may wish to consider long-term antibiotic prophylaxis. The management of rheumatic fever is geared toward the reduction of inflammation with anti-inflammatory medications such as aspirin or corticosteroids. Individuals with positive cultures for strep throat should also be treated with antibiotics. Aspirin is the drug of choice and should be given at high doses. One should watch for side effects like gastritis and salicylate poisoning. In children and teenagers, the use of aspirin and aspirin-containing products can be associated with Reye's syndrome, a serious and potentially deadly condition. The risks, benefits, and alternative treatments must always be considered when administering aspirin and aspirin-containing products in children and teenagers. Ibuprofen for pain and discomfort and corticosteroids for moderate to severe inflammatory reactions manifested by rheumatic fever should be considered in children and teenagers. Vaccine. No vaccines are currently available to protect against S. pyogenes infection, although research is underway to develop one. Difficulties in developing a vaccine include the wide variety of strains of S. pyogenes present in the environment and the large amount of time and people that will be needed for appropriate trials for safety and efficacy of the vaccine. Infection. People with positive cultures for Streptococcus pyogenes should be treated with penicillin as long as allergy is not present. The use of antibiotics will not alter cardiac involvement in the development of rheumatic fever. Some suggest the use of benzathine-benzylpenicillin. Monthly injections of long-acting penicillin must be given for a period of 5 years in patients having one attack of rheumatic fever. If there is evidence of carditis, the length of therapy may be up to 40 years. Another important cornerstone in treating rheumatic fever includes the continual use of low-dose antibiotics, such as penicillin, sulfadiazine, or erythromycin, to prevent recurrence. Inflammation. While corticosteroids are often used, evidence to support this is poor. Salicylates are useful for pain. Steroids are reserved for cases where there is evidence of an involvement of the heart. The use of steroids may prevent further scarring of tissue and may prevent the development of sequelae such as mitral stenosis. Heart failure. Some patients develop significant carditis which manifests as congestive heart failure. This requires the usual treatment for heart failure: ACE inhibitors, diuretics, beta blockers, and digoxin. Unlike normal heart failure, rheumatic heart failure responds well to corticosteroids. Hope this video will help you a lot about knowing the rheumatic fever. If you like our video, please do comment below and press the subscribe button. Thank you all.